Well, it is my great pleasure to open the second webinar of this conference, which is going to be broadcasted live via the Neurosurgical TV across the globe, covering the broad topic, technological advances ranging from blood-brain barrier and intra-arterial chemotherapy to the novel approaches of the therapeutic brain delivery and new strategies to overcome problems of conventional delivery. As the first speaker, we have Dr. Neuwelt from the Oregon Health and Science University in Portland, USA, talking about the blood-brain barrier in brain tumor therapy, intra-arterial chemotherapy.
Thank you. And I have to tell you that the co-author ought to be Mary. I got the slides back 3 times and I tried not to put too many slides in so there's time for questions. So brain tumor therapy, delivery and efficacy. One problem that we all know about is the delivery. But the other problem is we got to deliver something that kills the tumor and doesn't kill the brain. And that's a tough combination to deal with. Long-term disease control is possible, even using standard chemotherapy in chemo-responsive tumors, such as CNS lymphoma. And we'll show you some of that. But what about glioblastoma and other non-chemo-responsive tumors? We need better agents as well as better delivery. IV administration results in low CNS delivery. We all know that. Effective treatment requires penetrating the blood-brain barrier to reach the perivascular and diffusely infiltrated brain parenchyma. So, how do we deliver chemotherapy to the infiltrated tumor? This is a slide by our neuropathologist, Dr. Wiltshire. Pink is the IBA1, the macrophages, and that, as we heard at the end of the last presentation, macrophages, macrophages, macrophages. 40% of primary CNS lymphoma are macrophages. 40% of glioblastoma are macrophages. So that's a big word. And here, the brown is the CD20 for primary CNS lymphoma. And perivascular disease is very infiltrative, and the vasculature is involved far distant from the main tumor bulk. And so IV chemotherapy does not effectively treat this. Now, I think this is an important slide. Heterogeneous permeability of the blood-brain barrier. This is a model of hematogenous brain metastasis where we inject the human metastatic tumors in a new rat up one carotid artery. And you can see there's this big tumor and this big tumor. This is with AIB, amino isobutyric acid. And this big tumor here takes up the unidirectional flux agent AIB very little, whereas this one takes it up a lot. It's consistently inconsistent. And quantitative autoradiography shows this very nicely. And then over here, there's some cells, some tumors that are very leaky. But there's a lot that are barely more leaky than normal brain. And that's what we have to deal with. It's like what sank the Titanic, not the iceberg that stick up through the water. It was all the iceberg under the water that we can't see. And this is an old slide, 50 years old, showing that lanthanum between 2 endothelial cells stops at the first electron-dense tight junction. And that's where the blood-brain barrier is. We don't use the word blood-brain barrier anymore. We call it the neurovascular unit. And we can improve delivery of chemotherapy with an intra-arterial route of administration. And I'll show you an example in a couple of pediatric tumors. It shows that when the tumor is really leaky, as it is in pilocytic astrocytomas, you don't really need to open the blood-brain barrier. But first, let's look at osmotic opening with intraarterial chemotherapy after intraarterial delivery. Here we have IV versus IA, taking methotrexate, which has a molecular weight of about 500. IV is more to the gray matter because there's more vasculature, but just giving it intraarterially into the internal carotid or into the vertebral dramatically increases delivery. And there's, even in the very leaky tumor, IA is better than IV. So you can do it both into the carotid, into the vertebral, and even in a leaky intracerebral tumor in rat, intraarterial will improve delivery over intravenous. Intraarterial platinum chemotherapy and unresected pilocytic astrocytoma. We've treated a few of these that we get away from the pediatric neuro-oncologist, but we've been pleased that the few that we've done have generally done very well. There's a modest complication rate. This is a young boy that we first treated when he was about 7 years old. And he was treated with multiple chemotherapy regimens, but one was carboplatin, etoposide, and Cytoxan. And despite that, in a couple of decompressions and some focused radiation, he was rapidly losing vision in one eye and completely lost it in the other eye. And I like this case because we took the exact same drugs, carboplatin, etoposide, and Cytoxan. And because we gave it intraarterially, we don't do area under the curve. And gave 30% less drug and got a dramatic response. This went to that, and there it is. And this boy I saw about 5 years ago playing soccer. He's now in college. So carboplatin just given intraarterial versus IV at a smaller dose had a dramatic long-term response in this young child. Now this is a tumor that none of us would have thought was a pilocytic astrocytoma. This is a 24-year-old woman who we gave 9 courses of carboplatin and melphalan, and then 2 courses of carboplatin alone. There was some hypersensitivity to the carboplatin and some hemorrhagic cystitis, but nothing substantial. And there is a ring-enhancing lesion biopsy, clearly a pilocytic astrocytoma. There is sequential, and she's now, I think, 7 years out with absolutely a normal scan and no neurologic test. Just intraarterial carboplatin-based chemotherapy. Now this was a 13-year-old, I think, when we started. This is now a lawyer. She had a big cystic tumor which was at an outside hospital taken out, but we were very concerned that this may be involving some of the veins. So we shrank it with intraarterial therapy monthly for the times 12 months. She's now 28 years old and a practicing lawyer, and this hasn't changed in more than 10 years. The median progression-free survival was 31 months. The median overall survival was 70.8 months. So that was IA platinum-based chemotherapy. And now, intraarterial alone is better than nothing. But in older patients, even with blood-brain barrier disruption, Uh, we don't do real well in patients that are more than 75 years old. So here's the age range of 17 patients who received IA, because we don't do disruption in patients over 75. The KPS was about 50, and the mean number of treatments was 2.6. Three patients had a complete response, and 2 patients had a partial response. And here's the survival. Now, the survival is 0, 50, and 100 months. So there was some reasonable increase in survival with blood-brain barrier disruption, but we're reticent to do that in people over 75. Safety of intra-arterial therapy. Number of patients is 48 patients. The number of intra-arterial chemotherapy infusions was 206, carboplatin based, and there were 2 focal seizures and not much else. But if you combine intra-arterial with blood-brain barrier disruption, you can do better. This is a slide from Dr. Stanley Rappaport, who wrote the textbook on blood-brain barrier. But the intra-arterial mannitol was discovered by how many people are radiologists? The radiologists were studying angiography between 1945 and 1948, and they used a hypertonic iodinated solution and found that when they did this in rabbits, if they injected the contrast for 30 seconds or more at a rate that replaced the blood volume, they got an opening in the blood-brain barrier and the brain turned blue. This was basically forgotten. It was published in Acta Neurologica Scandinavica, which is still a published journal. And you cannulate the carotid up to about C2-3, or the vertebral is about C6-7, and you inject mannitol. It can't be 20% mannitol. It has to be 25%. And you have to make sure it's warm because you can get crystals at 25%. And you inject it for at least 30 seconds and just beat the blood pressure. And you can see when you do that, the tight lanthanum goes between these 2 endothelial cells. Here's the blood vessel to the abluminal side, because when it shrinks the endothelium, it opens the blood-brain barrier for about 30 minutes. And this is a slide from Dr. Rappaport's book. Here's the intravascular component, osmotic shrinkage, and the solutes that you're trying to deliver, which can be as large as herpes virus, which is 300 nanometers, can be delivered. You can't deliver cells, and you can deliver viruses up to 300 nanometers. And that's osmotic blood-brain barrier disruption. So it's really quite simplistic. I mean, it takes about 4 minutes to get puncturing the femoral artery to having a catheter in either the carotid at the level of C6-7 or in the vertebral at about C2. So there's the catheter, contrast agent, and up into the basement. And here we have the carotid. Now, barrier disruption improves delivery to the brain over IA or IV. So as you can see here, with methotrexate, which is the main drug for primary CNS lymphoma, you can see IV, IA, IV with blood-brain barrier disruption, and IV with intra-arterial disruption. And it goes up about 100-fold, not 100%, 100-fold compared. So if you gave 5 grams of methotrexate IV, you'd have to give 500 grams of methotrexate intravenously to get the same level we're getting in the brain. The rest of the body just sees normal levels of methotrexate. Basically 3 grams per meter squared is what we use. And if you want to deliver viruses or IgG, the barrier closes pretty quickly. So as you can see here, time after barrier modification, you need to get big molecules in the first 5 or 10 minutes. But it dramatically increases delivery up to 100-fold for up to 2 hours in small and large animals. And we originally, before we did patients, and I choked to tell you this, but we worked it out in dogs. We heard about that, but I have a dog, so I'm not sure I could do that. So let's look at an example. This is primary CNS lymphoma. Looks like a meningioma, except it's adjacent to the ventricle. So there's a lot of dense tumors that are leaky right there. So you see that that black band? That's dense tumor with an intact blood-brain barrier. And in fact, in primary CNS lymphoma, that's just the tip of the iceberg, because the lymphoma is all over the brain, no matter what the MR or CT scan shows. And the next day, we injected mannitol into the carotid artery. We got good opening in the anterior and middle cerebral artery circulation. The tumor didn't double in size. It's just this black band enhanced. And the cortex, which has much more capillaries than the white matter, has more white contrast from the iodinated contrast we give after the mannitol to document the blood-brain barrier opening. Or we can do it with radionuclide scan in IV blood-brain barrier disruption with the technetium glucoheptidine. So how do these patients do? Well, we started this in 1979 when I was still at the University of Texas Southwestern. And we did it based upon having done small animals and large animals, substantial amounts of molecular biology, cell biology, and did the first patient. And our purpose was to avoid radiation. I was declared a heretic for not giving CNS lymphoma whole brain radiation, because that was the definitive treatment. And you get a little bit of longer survival, but you get horrific dementia. And so in these patients, this was published in the Journal of Clinical Oncology. In the standard risk patients that are less than 60 with a Karnofsky greater than 60, those 47 patients, median survival, this is without Rituxan, was 10 to 12 years. That's without antibodies. And we did neuropsych testing on every patient before we treated them, and after we did it, had a year, and up to we've done periodic testing up to 30 years, and we have 4 or 5 patients that are between 25 and 30 years of age. One's an orthopedist in Arizona, one's a tax lawyer, Bloomfield Hill. We had no patients lose cognitive function. So immunotherapy in combination with BBVD improves response in patients. Based on our laboratory studies, we have 3 animal models of primary CNS lymphoma. In clinical efficacy with monotherapy in our rats. CNS lymphoma used frontline was added to increased delivery with blood-brain barrier disruption. And so here you see no methotrexate-based therapy, 149 patients, no monoclonal antibody, yes monoclonal antibody. Overall response went from 81% to 92. Complete response went from 57 to 75. But the overall survival went from 37 months to 61 months. And all of the other parameters were the same in both groups. Now, what's the safety? Since 1979, we've done 4,000 disruptions in 268 patients for a total of 2,134 courses of treatment, 2 disruptions a month in the course. The adverse event in these 4,000 disruptions, 4 patients showed ischemia on MR, which was not seen clinically, but it clearly was a small embolic phenomenon from those 4,000 catheter procedures. There were 4 adverse events due to iatrogenic laminate flow, which we fixed and sped up the rate of infusion of the chemotherapy. Focal seizures were common because methotrexate is leptogenic, but we rarely see any seizures. They're generally just a focal seizure. There were 2 deaths in 30 days, one from a brainstem stroke and one from a fulminant. So, in conclusion, intraarterial platinum can safely and effectively treat chemosensitive tumors such as pilocytic astrocytoma. Even using platinum, where the platinum is given intravenously, and blood-brain barrier disruption can safely be performed with appropriate training. There's nothing fancy or complicated. This takes a little logistic coordination between 3 or 4 different departments. Here's our group. It's been primarily funded by the NIH, which are 2 R01, 23 years and 35 years. VA Med Review, that just got renewed for the 40th consecutive year. More recently, we've done a little bit with companies, and we've had some help from the philanthropy. So there's our room, one window, and one of my fellows gave me this picture. So I tried to show just a few slides, because there's lots of people here, all kinds of horrific stories about blood-brain barrier disruption. And so I'm more than happy to take the attack, tell you what I know. Thank you.